Okay, morning friends. I'm Dr. Sushant Soni. I'm from AIMS Delhi and I'm your pathology faculty with the institute. So today, starting with the discussion of subject-wise test pathology part that in 2019. Firstly, how was the paper? There were 200 questions in the paper, and personally, I feel that it was a very balanced paper. This is the kind of paper we are expecting, especially in the All India exam, with few questions being catered to the AIMS paper as well. So let us start with the discussion and then we'll go forward as and when required. So starting with our first question. In hemochromatosis, arrange the following orders in decreasing severity. Now, this is arranged in the severity, that is the most common and the most severely affected organ is the liver, followed by heart, pituitary, adrenal and joints. So the answer is B. Question 1, the answer is B, that is 1, 2, 3, 4, 5. So before we go further, let us have a look at hemochromatosis. First point, starting with hemochromatosis, which metal is getting deposited? Iron. That is, this is excessive iron deposition. This is excessive iron deposition in which all are the sites where the iron is getting deposited? In the liver. In liver, followed by heart, that is myocardium, followed by heart, pituitary gland, followed by heart, pituitary gland, adrenal gland and joints. Adrenal gland and joints. First point. Next, hemochromatosis, the gene involved. The most common gene involved in hemochromatosis is the HFE gene mutation. It is the HFE gene mutation present on chromosome 6. Short arm, long arm? Short arm of chromosome 6, that is chromosome 6p. This is the same as that of HLA. Next point, hemochromatosis, the classification. Before we go to the classification, what is the inheritance pattern of hemochromatosis? It is autosomal recessive inheritance. You very well know that all the metabolic disorders are autosomal recessive. Next point, classification of hemochromatosis. Next point, classification. I can divide hemochromatosis into two main categories. That is, the first is hereditary hemochromatosis. The first is hereditary hemochromatosis, which is associated with mutations encoding HFE gene. Hereditary, which is associated with mutations encoding HFE. We have already seen that this is the most common gene mutation present on chromosome 6p. We have seen that mutations encoding HFE gene, TFR2 gene, that is transferrin TFR2, transferrin factor receptor 2 gene, transferrin receptor 2, TFR2, transferrin receptor 2 gene, transferrin receptor 2 and HJV. HJV, please put a star on this. HJV stands for hemojuvelin. HJV stands for hemojuvelin. HJV gene mutation, which is most commonly associated with, the name tells you, hemojuvelin, which is most commonly associated with juvenile hemochromatosis. Juvenile hemochromatosis. Next point, the next type of hemochromatosis. This was the hereditary type. Next is the secondary hemochromatosis. Secondary hemochromatosis, this occurs secondarily to something, that is iron overload. That is, it can occur because of parenteral iron overload, either because of repeated transfusions, parenteral iron overload because of repeated blood transfusions, hemodialysis, hemodialysis or MDS, myelodysplastic syndromes, MDS. So parenteral iron overload. Next, it can also be because of ineffective erythropoiesis, secondary hemochromatosis, ineffective erythropoiesis, as is associated with thalassemias, and the last is increased oral intake. Increased oral intake. Increased oral intake of iron would be associated with people living in which continent? Africa. So this is African iron overload or African hemosiderosis, African hemochromatosis, also called as Bantu siderosis, also called as Bantu siderosis, African hemochromatosis or Bantu siderosis. So classification of hemochromatosis, we divided hemochromatosis into two main types, that is the hereditary hemochromatosis and the secondary. Hereditary, the most common gene involved was HFE. Most common in juvenile hemochromatosis was HJV, hemojuvelin. Secondary hemochromatosis, parenteral iron overload, ineffective erythropoiesis and increased oral intake, that is Bantu siderosis. Next point. You very well know that the most common organs affected, the most common and the most severely affected organ, most common and the most severely affected organ is liver. You very well know this, where it is associated with which cirrhosis, micronodular or macronodular? Again, please put a star on this, where it is associated with micronodular cirrhosis, where it is associated with micronodular cirrhosis. What is micronodular? The size of the liver nodule is less than 3 millimeters. The size of the liver nodule is less than 3 millimeters. It is micronodular cirrhosis. Next point, hemochromatosis. It is also associated with bronze diabetes. Extremely important, bronze diabetes. See, the writing is coming slightly bad. This is not my original writing. This is coming slightly bad because of error in the pen. Bronze diabetes. First point, why is diabetes occurring? Diabetes is occurring because of deposition of iron in pancreas. Diabetes because of iron deposition in pancreas. So the work reduces. So the effective output of insulin reduces. Why bronze? Because which pigment is getting deposited in the skin? Put a double star on this. In the skin, it is associated with melanin deposition. In the skin, the main pigment that is getting deposited in hemochromatosis is melanin and hemosiderin. So both melanin and hemosiderin are getting deposited, but hemosiderin deposition is minor. Hemosiderin deposition is a minor component. The main pigment that is getting deposited in hemochromatosis in skin is melanin. Next point. Hemochromatosis, the diagnostic gold standard. The diagnostic gold standard for hemochromatosis. The diagnostic gold standard for hemochromatosis is quantitative assessment of tissue iron. Diagnostic gold standard is quantitative assessment of tissue iron. Quantitative assessment of tissue iron content. Next point, if the tissue iron is more than 10,000 microgram per gram dry weight, if the tissue iron content in the liver is more than 10,000 microgram per gram dry weight of liver, more than 10,000 microgram per gram dry weight of liver, it is suggestive of hemochromatosis. So the diagnostic gold standard is quantitative assessment of tissue iron content. Next point, the test of choice. The test of choice is genetic testing. The test of choice is genetic testing. And lastly, the risk of HCC, risk of hepatocellular carcinoma or HCC is increased 200 times the normal population, is increased 200 times the normal population. This is hemochromatosis and the associated secondary points which may be asked with this. Next, this gets us to our next question, that is question number 2. This gets us to question 2. Which of the following is a hemoglobin derived golden brown pigment and is the major storage form of iron? The answer is D, that is hemosiderin. The storage form of iron, the answer is D, that is hemosiderin. So let us have a look at this in more detail. Firstly, I can divide the pigments into two types, that is the endogenous pigments and exogenous pigments. Endogenous and exogenous. The endogenous pigments, they are three, that is lipofusion. Endogenous pigments are three, that is lipofusion, melanin and hemosiderin. So there are three endogenous pigments, that is lipofusion, melanin, hemosiderin, versus the main exogenous pigment, which is carbon. I'm not interested in carbon. Let us have a look at the endogenous pigments one by one. Starting with the first endogenous pigment, that is lipofusion. Sorry. First point, lipofusion. You very well know it is the wear and tear pigment of the body. Lipofusion, it is the wear and tear pigment. Of the body. So it is the telltale sign. Of free radical injury. Next point, lipofusion. Microscopically, it is golden brown in color. So, next point, it is associated with aging. So, the lipofusion deposition in the heart is called as brown atrophy. It is called as brown atrophy of the heart. And the stain used for lipofusion is the long Zn stain. Ziehl-Neelsen stain. So you very well know that Ziehl-Neelsen stain is used for tuberculosis. If the staining time is increased, that is the long Zn stain that is used for lipofusion. Next, the next endogenous pigment. Is melanin. First point, melanin, the normal sites where melanin is present. First point, you very well know that it is present in skin. That is why we get the dark complexion because of melanin. It is present in skin, hair follicles, iris. These 3 points everybody knew. What you have to remember is it is also seen in stria vascularis of inner ear. locus ceruleus, locus ceruleus and substantia nigra of the brain. Locus ceruleus and substantia nigra. Locus ceruleus and substantia nigra of the brain. These are the normal sites of melanin. Next point, put a star on this. IHC, immunohistochemistry. IHC, immunohistochemistry for melanin is HMB45. Immunohistochemistry, HMB45 and S100. Which is more specific for melanin? HMB45 or S100? More specific. More specific for melanin, HMB45. Next point, the stain used. The stain used for melanin is the Mason-Fontana stain. Stain used is the Mason-Fontana stain. Mason-Fontana stain. Next, this gets us to our last endogenous pigment and the one which was asked in the question, that is hemosiderin. This gets us to our last endogenous pigment, that is hemosiderin. That is hemosiderin. First point, hemosiderin, this is a heme-derived pigment. Very obvious. This is a heme-derived pigment. This is a heme-derived pigment, and microscopically it is golden yellow to brown in color. Microscopically it is golden yellow to brown in color. Next point, hemosiderin, it is seen at sites of local hemorrhage. Hemosiderin, it is seen at the sites of local hemorrhage or bruising. It is seen at sites of local hemorrhage. And the stain used, see the metal is iron, the stain for iron is Prussian blue. Stain used is the Prussian blue or pearl stain. Prussian blue or the pearl stain. This is the one which is associated with the storage. So in ferritin forms hemosiderin granules. So this was the question, that is which is hemoglobin derived golden yellow to brown and major storage forms of iron, that is hemosiderin. Next, this gets us to question 3. Acridin orange is a fluorescent dye used to bind DNA and RNA. Question number 3, the answer is A. Question number 3, the answer is A, that is it is used to bind DNA and RNA. It is used to bind DNA and RNA. So before we go further, let us have a slightly more look at this. Acridin orange, my mistake, just a sec, let me correct the spelling. Acridin orange, this is a nucleic acid selective. Acridin orange, this is a nucleic acid selective fluorescent dye. It is a nucleic acid selective. It is a nucleic acid selective fluorescent cationic dye. It is a nucleic acid selective fluorescent cationic dye. Fluorescent cationic dye. Next point, the name tells you everything. It is nucleic acid selective in nature. As a result, it is cell permeable. As a result, it is cell permeable and interacts with DNA and RNA. It is cell permeable and interacts with DNA and RNA. Next point, the first role is it is interacting with DNA and RNA and is used to bind with it. Next, it can also be used to differentiate between. Next point, it is used to differentiate between. Just a sec. It is used to differentiate between live and apoptotic cells. It is used to differentiate between, if N is somehow not working, it is used to differentiate between live and apoptotic cells. By the use of the dye, ethidium bromide, by the use of the dye, ethidium bromide. So acridine orange along with ethidium bromide is used to differentiate between live and apoptotic cells. Next. So this gets us to question number 4, that is, which of the following complement is activated by both common as well as the alternative pathway? And the answer is C, that is C3. Question 4, the answer is C, that is C3. Now before we go further, let us have a look at the complement pathways. You very well know that there are 3 complement pathways. The classical complement pathway, which starts from C1, involves C2, C4, goes to C3, C5, and then MAC. MAC stands for membrane attack complex. MAC is membrane attack complex, composed of C5 A, B, C5B to C9. This is the classical pathway. Next is the alternative pathway and minoselectin binding pathway. Alternative and minoselectin binding pathway, which converge directly on C3. So the question was, all the complement pathways, they converge on C3. Next point, much more important than the complement pathways are the diseases associated with complement pathways. With complement pathways. First point, the most common is deficiency of C2. Most severe. Where was everything converging? C3. So most severe is deficiency of C3. Next, early complement protein defects. Is associated with lupus, that is SLE, versus late complement protein defects, which is associated with increased risk of infections. Late complement protein defects associated with increased risk of infections with toxoplasmosis and Neisseria gonorrhoeae. So late complement protein defects, increased risk of infections with toxoplasmosis and Neisseria gonorrhoeae. Next point, deficiency of C1 esterase inhibitor, that is C1 esterase inhibitor deficiency. C1 esterase inhibitor deficiency is associated with hereditary angioneurotic edema. C1 esterase inhibitor deficiency, hereditary angioneurotic edema. Next, deficiency of CD55 and 59. Deficiency of CD55 and CD59 is associated with which hemolytic anemia? PNH, paroxysmal nocturnal hemoglobinuria, PNH. And last is deficiency of complement factors. B, H and I. Deficiency of complement factors B, H and I is associated with atypical HUS. HUS stands for hemolytic uremic syndrome. Atypical HUS. So much more important than the complement pathways are the diseases associated with deficiency of complement factors. Next point. This gets us to our next question, that is question number 5. Lines of Zahn occur in which of the following? Question 5, and the answer is D, that is Coralline thrombus. Question 5, the answer is D, The answer is D, that is coralline thrombus. Coralline thrombus. Now, before we go further, let us have a look at this in more detail. Thrombosis is an important topic. First point, I can divide the thrombus into two types, that is arterial thrombus and venous thrombus. I can divide the thrombus into two types, arterial and venous thrombus. First point, starting with arterial thrombus, the propagation of the thrombus, both are towards the heart. Now, arteries, they come from heart and go to the peripheral tissues. So in arterial thrombus, the propagation is retrograde. The propagation of the thrombus is retrograde versus venous thrombus, in which it is antegrade. Antegrade is, it is in the direction of the flow. In direction of the flow of blood, that is antegrade. Next point, occlusion. Occlusion. Arterial thrombus usually does not occlude the blood vessel. It usually does not occlude the blood vessel versus venous thrombosis, in which occlusion is usually present. Next point, sites. The most common sites of arterial thrombus are the coronary vessels, followed by cerebral, and femoral arteries. Sites, coronary, cerebral, femoral, versus the venous thrombus, where the sites are more commonly the veins of lower extremities. This is the most common site of venous thrombus, the veins of lower extremities, followed by upper extremities, and periprostatic plexus. This is the venous thrombus, the sites. Next point, grossly. Arterial thrombi are white thrombi. Arterial are the white thrombi, as more commonly they contain platelets. Versus venous thrombi, which are the red thrombi. As they more commonly have red cells with few platelets. This is thrombus, arterial versus venous. This table is important, arterial versus venous thrombi. Next point, how do we differentiate between before death, antemortem versus a postmortem in thrombus? First point, both arterial and venous thrombi, both arterial and venous thrombi, both of them, the arterial and the venous thrombi, have laminations. They show the presence of laminations called as lines of Zahn. They show laminations called as lines of Zahn. This is important. What are they? These are pale platelet and fibrin deposits. These are pale platelet and fibrin deposits. Which are alternating with darker red cell layers. Darker red cell rich layers. So what is happening here is, The platelets and the fibrin deposits, they are darker, they are lighter stained, alternating with the darker red cell layers, leading to laminations, which are called as lines of Zahn. This distinguishes a antemortem clot. This distinguishes an antemortem clot from bland postmortem clots. So antemortem clots show the presence of lines of Zahn. Antemortem clots show the presence of lines of Zahn versus the postmortem clots in which are gelatinous in nature, and the dark red is the dependent settled portion. Dark red dependent portion is settled by gravity. Dark red dependent portion is settled by gravity, leading to the presence of a yellow chicken fat upper portion. Yellow chicken fat upper portion. This is a postmortem clot. Of course, postmortem clot is not attached to the blood vessel. So now let us have a look at the question again. Lines of Zahn occur in antemortem clots, also called as the coralline thrombus. This is antemortem versus postmortem clots. Antemortem clots show the presence of lines of Zahn. Next, this gets us to our next question, that is question number 6. Just a sec. This gets us to our next question, that is question 6. Having a look at question 6, true statement about inheritance of an X-linked recessive trait is 50% of the boys of carrier mother are affected. The first statement is true. Let us have a look at this. Carrier mothers, let us assume that this is a carrier female, mating with a normal male. X dot X, XY leads to the presence of this X dot X, X dot Y, XX, XY. So there are two male kids, one of which is affected. As a result, in X-linked recessive inheritance, the answer is A. That is 50% boys of carrier mother. 50% boys of carrier mother are affected. 50% boys of carrier mother are affected. Next point, let us have a look at the other options. Option B, 50% of girls of deceased father are carriers. 50% girls of deceased father. Nahi bache, if the father is affected, then all the girls are carriers, not 50%. Father transmits the disease to the son. Never. Because father's Y chromosome goes to the son, not the X chromosome. Mother transmits the disease to the daughter. Question number 6, again no, this is not true. So the answer is A. Question 6, the answer is A. Next point, another important topic in X-linked recessive inheritance are the diseases associated. With X-linked recessive inheritance. This again is asked, diseases associated. First point, starting with the hematological diseases, they are XH, that is hemophilia. We write hemophilia as XH. Next, which is the most common RBC enzyme deficiency? G6PD deficiency. Next, which disease of innate immunity has a X-linked recessive inheritance? CGD, that is chronic granulomatous disease. Next, color blindness. Easy to remember. We guys, we are colorblind in nature. Red, yellow, green, blue. So color blindness. Next, Duchenne's muscular dystrophy. Duchenne's. Duchenne's muscular dystrophy. And the last is VASP, that is Wiskott-Eldridge syndrome. And the last is Wiskott-Eldridge. Wiskott-Eldridge syndrome. These are the diseases. These are the diseases associated with an X-linked recessive inheritance. Has to be remembered. Next point. Another question that is asked is X-linked recessive inheritance. Male predominant, female predominant? Of course, it is male predominant. X-linked recessive. Male is XY, so X dot Y, X-linked recessive, male predominant. Versus X-linked dominant inheritance, which is female predominant. First point, X-linked dominant, which is female predominant. Why? There are two reasons for this. First is greater number. First is greater number of X chromosomes in the female. And the second is some X-linked dominant diseases. Some X-linked dominant diseases are lethal in utero in males. Lethal in utero means that if a male child is suffering from X-linked dominant disease, he dies in the womb of the mother. Lethal in utero. Which is the main cause of X-linked dominant being female predominant? Greater number or lethal in utero? Greater number. The main cause is greater number. Next point. Diseases associated with X-linked dominant inheritance. Diseases associated with X-linked dominant inheritance. They are Alport syndrome, hypophosphatemic rickets, also called as vitamin D resistant rickets, hypophosphatemic or vitamin D resistant rickets, Rett syndrome and Charcot-Marie-Tooth disease. Rett syndrome and Charcot-Marie-Tooth disease. These are the diseases associated with an X-linked dominant inheritance. Next point. This gets us to our next question, that is question number 7. This gets us to question 7. Let us have a look at this. 45 male shows nodule near the L of the nose, which is gradually increasing in size. Punch biopsy shows this lesion. Now, treat this as a no history slide. What you see in the image itself is, this image is self-explanatory. We need nothing other than the image. What this shows you is, we see the presence of stratified squamous epithelium at the top with presence of tumor cells which have palisading of the nuclei. At the periphery, look at the ones I am showing with the arrow, the nuclei are palisaded with presence of this white area around it, that is the retraction cleft. This is the classical image of basal cell carcinoma. This is the classical image of basal cell carcinoma. So question number 7, the answer is B, that is basal cell carcinoma. Basal cell carcinoma, also called as rodent ulcer. So before we go further, let us have a look at few salient features of basal cell carcinoma. First point, basal cell, is it a benign tumor or is it locally aggressive? Locally aggressive. Basal cell carcinoma, it is a locally aggressive. It is a locally aggressive cutaneous tumor. It is a locally aggressive cutaneous tumor which is the most common invasive skin cancer of humans. It is the most common invasive skin cancer with most common site being face. Most common site being face. Now, even in the face, it has a characteristic location, that is, it is present above a line. It is present above a line from the lobe of the ear, above a line from the lobe of ear to corner of the mouth, from the lobe of ear to corner of the mouth. That is, if we draw an imaginary line from the lobe of ear to the corner of the mouth, it occurs above this line. It occurs above this. Next point, basal cell carcinoma. It is associated with hedgehog pathway signaling. It is associated with hedgehog pathway signaling. Hedgehog pathway signaling. And it is a slowly growing tumor. It is a slowly growing tumor which metastasizes rarely. That is metastasis. Metastasis is infrequent. Metastasis is infrequent. It is infrequent. This is basal cell carcinoma. This is basal cell carcinoma. Next point. So before we go further, let us see what it looks like microscopically. This is basal cell. Microscopically it shows palisaded tumor cells with palisaded baseloid tumor cells with presence of a retraction cleft. Basal cell carcinoma. Next, this gets us to question 8, that is, MHC restriction to antigen presentation is not done for, and the answer is D, that is graft rejection. Question number 8. The answer is D, that is graft rejection. That is graft rejection. MHC restriction. MHC, major histocompatibility complex. It is used for killing of virus by cytotoxic cells. Let us have a look at the other options. It is used for killing of the virus by cytotoxic cells, killing of bacteria by helper cells, and T cell activation and autoimmunity. It is used in all those, not in graft rejection. Next point. So before we go further, let us have a look at MHC in more detail. First point, MHC, major histocompatibility complex, or HLA, human leukocyte antigen, MHC or HLA. In second year, they could have asked you the difference between the two. MHC is for all mammals. HLA is only for humans. We are human doctors, so second year onwards, it's the same for us. I can divide MHC into two types, type 1 and type 2 MHC. Type 1, it is actually of three types. Let us first make a table of type 1 and type 2 MHC. First point, MHC, it is present on which chromosome? Chromosome 6p, that is short arm of chromosome 6. Next point, what is the main role of MHC? To process and present the antigen to other cells. So does it process few antigens or a variety of antigens? It processes a variety of antigens. That is, it is highly polymorphic. MHC, it is highly polymorphic. It is highly polymorphic. Next point, starting with the sites. MHC type 1, it is present on all nucleated cells. It is present on all nucleated cells and platelets, versus MHC2, which is present on professional antigen presenting cells, versus MHC2, which is present on professional antigen presenting cells. Which are the professional antigen presenting cells? They are dendritic cells, macrophages and B cells. Dendritic cells, macrophages and B cells and B cells. Next point, just a sec, let me rub this, yes. Next point, the genes associated. Type 1 MHC, it is associated with all the single digit genes, that is HLA A and B, HLA A, B and C, versus type 2 MHC, which is associated with double digit genes, HLA DP, DQ, DR, HLA DP, DQ, DR. Next point, type 1 MHC, the antigen presenting site. The antigen presenting site. In type 1 MHC, it is rank 1, so everything is alpha alpha. The antigen presenting site is alpha 1 alpha 2 versus type 2 MHC alpha 1 beta 1. You very well know which T cells are MHC type 1 restricted. They are the CD8 positive T cells versus CD4 positive T cells, which are MHC2 restricted. You know this. Next point, MHC type 3. Next point, MHC type 3, it secretes 4 things, that is it secretes tyrosine hydroxylase, it secretes tyrosine hydroxylase, TNF alpha, tumor necrosis factor alpha, heat shock protein 70, HSP 70, heat shock protein 70, and complement factors B, H and I. Complement factors B, H and I. This is type 3 MHC. Last point, much more important than MHC are the diseases associated with MHC. Are the diseases associated with MHC. They are, starting with the most famous one, that is HLA B27. Starting with the most famous HLA B27, it is associated with 4 diseases, which are ankylosing spondylitis, Reiter's disease, ankylosing spondylitis, Reiter's disease, reactive arthropathy, and psoriatic arthropathy, reactive arthritis and psoriatic arthropathy, HLA B27. Next, which GIT disease is associated with HLA? Celiac disease. Which HLA? HLA DQ2/DQ8. What is celiac disease? It is gluten sensitive enteropathy. Celiac disease, gluten sensitive enteropathy, that is the intestines are sensitive to gluten sensitive enteropathy. Next, which vasculitis is associated with which HLA? Thromboangiitis obliterans. Thromboangiitis obliterans associated with HLA B5. What is the main feature of thromboangiitis obliterans? This is associated with smoking. So vasculitis having the strongest association with smoking, thromboangiitis obliterans, HLA B5. Next, others are, just to complete the list, others are HLA DR2, good pastures syndrome, HLA DR3, Sjogren's syndrome, HLA DR3, Sjogren's syndrome, in Sjogren's S is silent, HLA DR4, rheumatoid arthritis, Next, HLA A1 and B8, HLA A1 and B8 is associated with sarcoidosis. A1 and B8 sarcoidosis. These are the diseases associated with HLA. Diseases with HLA. This page again is asked. Next point. Next point. This gets us to our next question. This gets us to our next one, that is question 9. All of the following are used for diagnosis of HIV in 2-month-old child, except. Now, this is sort of an obvious question. The answer is C, that is HIV ELISA. The answer is C, that is HIV ELISA. Question number 9. Question 9. The answer is C, that is HIV ELISA. Now, let us have a look at this. Now, the first point, when you see this question, you can ask, we do not know which all tests are used at which all age time periods. But in ELISA, we look for the presence of antibodies. Because these antibodies are IgG type, if the mother is affected, the antibodies can cross the placenta and reach the fetus. So if the fetus shows, or if the child shows IgG anti-HIV antibody, this does not mean that the child is HIV infective. So all can be used at birth. So the question was, all are used for diagnosis of HIV in 2-month-old child, except we can use PCR culture or P24 antigen assay. What we cannot use is HIV ELISA. So let us write this. Let us write this. First point. HIV ELISA, it detects the antibodies against the virus. It detects the presence of antibodies. It detects the presence of antibodies against the virus. It detects antibodies. Next point. In infant, they can be false positive. The test can be false positive because IgG maternal antibodies can cross the placenta. They can cross the placenta. So point of antibodies in a 2-month-old child is not diagnostic. It is not the appropriate test. Next point. With respect to HIV, numerous other one-liner questions are also asked. So let us have a look at those. First question: the most common fungal infection associated with HIV is Candida albicans. Most common fungal infection associated with HIV, Candida. Next point, what are the sites of these candidiasis? It occurs in oral cavity. It occurs in the oral cavity, vagina, and esophagus. Oral cavity, esophagus, and vagina. Next point. Most common malignancy in HIV. Most common malignancy is non-Hodgkin's lymphoma followed by Kaposi sarcoma. Non-Hodgkin's lymphoma followed by Kaposi sarcoma. Next point, Kaposi sarcoma is also associated with which viral infection? HHV8. So I can rephrase this as HHV8 is associated with 3 things, that is primary effusion lymphoma, Castleman disease, and Kaposi sarcoma. So you need to know this both ways. Next point, most common CNS space occupying lesion. Most common CNS mass lesion or space occupying lesion in HIV, toxoplasmosis gondii. Most common space occupying lesion, toxoplasmosis gondii. Next point, most common hematological manifestation. Most common hematological manifestation. Hematological manifestation with HIV is anemia. Most common hematological manifestation both before therapy as well as post ART therapy. Next question. Most common extranodal site of non-Hodgkin's lymphoma. Put a star on this. Most common extranodal. Most common extranodal non-Hodgkin's lymphoma. What do we mean by this? Lymphoma is malignancy of lymph nodes. Lymphoma is of two types, Hodgkin's, non-Hodgkin's. Most common extranodal, that is which is occurring outside the lymph node. What are the usual sites of extranodal lymphomas? GIT, that is stomach, intestines, CNS. Most common site of extranodal non-Hodgkin's lymphoma in general population is stomach, whereas in HIV is CNS. Next point, most common non-Hodgkin's lymphoma. Next point, most common non-Hodgkin's lymphoma in HIV is DLBCL, diffuse large B-cell lymphoma. DLBCL followed by Burkitt's lymphoma. DLBCL followed by Burkitt's lymphoma. Next point, most common Hodgkin's lymphoma associated with HIV, mixed cell RT. Next point, most common Hodgkin's lymphoma associated with HIV. Overall, most common in India is mixed cell RT. The one with HIV is also mixed cell RT. These are the one-liners. Most common nephrotic syndrome associated with HIV, FSGS. Focal segmental glomulosclerosis. Most common nephrotic syndrome associated with HIV, FSGS. Focal segmental glomerulosclerosis. And which subtype of FSGS? The collapsing type. Which subtype of FSGS? The collapsing type. Done. This takes care of the one-liners associated with HIV. So which test should not be used in a 2-month-old child? ELISA, because antibodies can cross. Next, this gets us to question number 10. Most favored site of endometriosis. Firstly, what is endometriosis? Presence of endometrial tissue which is responding to menstruation outside the uterus. Most common site of endometriosis is ovary. Question 10. Question number 10. The answer is B, that is ovary. The answer is B, that is ovary. Next point. In descending order, though this I am sure would have been covered in obs-gynae, the sites of endometriosis are ovary. In descending order, they are ovary, uterine ligaments, followed by rectovaginal septum, cul-de-sac, peritoneal peritoneum, followed lastly by laparoscopic scars. So the points to be remembered were: most common is ovary, followed by uterine ligaments, and one of the least common sites is laparoscopic scars. This is endometriosis, that is presence of endometrial tissue outside the uterus. Next, this gets us to our next question, that is question number 11. Question 11. On renal biopsy, the past periodic acid shift positive structures are The answer is 1 to 4. GBM, tubules and mesangial matrix. Question 11. The answer is A. Answer is A, 1 to 4. That is GBM. Glomerular basement membrane, tubules, and mesangial matrix. Now, before we go further, let us have a look at stains used in renal biopsy. That is, let us have a look at renal stains. First point, there are 3 renal stains, which are PAS, that is periodic acid Schiff, which stains the GBM, glomerular basement membrane, mesangial matrix, which stains glomerular basement membrane, mesangial matrix, tubular epithelium, and Bowman's capsule. Next point, it is the most useful stain in renal biopsy. That means if I have to use one stain in renal biopsy, the one that I will be using is PAS, periodic acid Schiff. Next, the next renal stain is MT, that is Mason's trichrome. The name tells you everything. Trichrome, 3 colors. So what are the 3 colors with MT? Blue green, which is for collagen, red, which is for muscle, and black, which is for nuclei. MT, Mason's trichrome. So MT, it is used to differentiate smooth muscle hypertrophy from fibrosis. What do we mean by this? Smooth muscle hypertrophy is red in color, fibrosis would be blue-green in color. Why do we need to differentiate between the two? Because on H&E, both look similar. Next, the next is SM. The next stain is SM, that is silver methenamine. It is used to differentiate hyaline deposit from sclerosis. Sclerosis is SM positive. Sclerosis is silver methenamine positive. These are the 3 renal stains: PAS, Mason's trichrome, and silver methenamine. Next point, which is the most useful renal stain? PAS, periodic acid Schiff. Next question, most specific for basement membrane. PAS nahi bache. PAS is staining structures other than the basement membrane also. Most specific, SM, silver methenamine. So I can safely say stain of choice for MPGN. MPGN, what is the diagnostic hallmark? It is splitting of the basement membrane, giving it the double contour or the tramp track appearance. So stain of choice for MPGN, silver methenamine. Next point. This gets us to our next question, that is question 12. This gets us to question number 12. Characteristic lesion of diabetic kidney, known as KW lesions, is also known as nodular glomerulosclerosis. Question 12. The answer is C. Question number 12. The answer is C. That is nodular glomerulosclerosis. First point, let us start with diabetic nephropathy. nodular glomerulosclerosis. Now, starting with diabetic nephropathy, that is diabetes affecting the kidney. Diabetic nephropathy occurs by two patterns, that is diffuse glomerulosclerosis. It occurs by two patterns, diffuse glomerulosclerosis and nodular glomerulosclerosis. Diffuse glomerulosclerosis and nodular glomerulosclerosis. First point, which is more common? Diffuse glomerulosclerosis. More common, diffuse glomerulosclerosis versus more specific, which is nodular glomerulosclerosis. More specific, nodular glomerulosclerosis. Next point, nodular glomerulosclerosis, it is also associated with KW lesions, also called as Kimmel-Stale-Wilson, Kimmel-Stale-Wilson mesangial nodules or lesions. This was the question. KW, Kimmel-Stale-Wilson mesangial nodules or lesions. Next point, diabetic nephropathy. Diabetic nephropathy, it is associated with the presence of insudative changes. It is associated with the presence of insudative changes. Insudation, this is a pen which is insudating into my fingers. It is entering into my fingers. So if this is the glomerulus, something seems to be entering inside. So the capillaries form a U-shaped structure. Something is entering inside it. It looks like a cap. So the insudative changes with diabetes are fibrin caps and capsular drops. Fibrin caps and capsular drops. Next point, before we go further, this is what a KW lesion looks like. Let us have a look at this. Have a look at this in an unbiased manner, that is, you do not know anything about this image. Still, we are able to make out that it shows the presence of a glomerulus. This is a glomerulus in which capillaries have aggregated to form nodular lesions, that is nodular glomerulosclerosis. Nodular glomerulosclerosis associated with diabetes. Next point, this gets us to our next question, that is question number 13. Microarray is best characterized by, the answer is A, that is study of multiple genes. Question 13, the answer is A, that is microarray. It is characterized by study of multiple genes. It is characterized by the study of multiple genes. What do we mean by this? See, microarrays, they are gene chips. Microarrays, they are gene chips. They are the gene chips used to sequence genes or portion of genes. They are used to sequence the genes. So I can safely say that microarrays are used for study of multiple genes. Next point. In this technique, what is the principle? In this, short sequences of DNA, that is the oligonucleotides. Short sequences of DNA, that is oligonucleotides, that are complementary to the wild type. Short sequences of DNA that are complementary to the wild type sequence. That are complementary to the wild type sequence. Wild type is the normal type of sequence, that are complementary to the wild type sequence and to known mutations. Are tiled adjacent to each other. That is, they are put adjacent to each other on the gene chip. They are tiled adjacent to each other on the gene chip, and the DNA sample to be tested is hybridized. That is, what is happening here is the oligonucleotides which are complementary to the wild type. Wild type is the normal DNA. We have taken a self-manufactured oligonucleotide which is complementary to the normal DNA, and to the known mutations they are tiled adjacent to each other on the gene chip. Next point, DNA sample to be tested is hybridized to the array. Next point, DNA sample to be tested is hybridized. DNA sample to be tested is hybridized to the array. Next point, if the sample is mutated, the complement will get hybridized to the mutant DNA. In presence of a mutation, if DNA sample to be tested is hybridized. Next point, in presence of a mutation, this will cause hybridization. This causes hybridization to occur at complementary mutant oligonucleotide. Meaning oligonucleotide. That is, if there is no mutation, hybridization will occur to the wild type, whereas if mutation is present, hybridization will occur to the complementary mutant oligonucleotide. So by microarray technique, a study of multiple genes is performed together. Next point, this gets us to our next question, that is question 14. Now in this question, even the history is not needed. Let us though have a look at the history. It says 50-year-old male, reflux, burning pain, biopsy is performed, what is the diagnosis? Have a look at this question, have a look at this. It is showing you the presence of numerous columnar cells with arrow being pointed on goblet cells, firstly. Second, you also have a lymphoplasmacytic infiltrate. So diagnosis in this case is D, that is Barrett's esophagus. Question 14. The answer is D, that is Barrett's esophagus. What is Barrett's esophagus? It is intestinal metaplasia. That is, the word metaplasia is one lining changing to another. The word before the metaplasia is the end lining. So what is happening in Barrett's is the normal stratified squamous epithelium is getting converted to columnar. Now I'm not satisfied with the word columnar. The exact word is intestinal epithelium. Why? Because it shows the presence of columnar cells along with goblet cells. Goblet cells are also present. Next point. Barrett's esophagus. The main risk factor is GERD, gastroesophageal reflux disease. Because of reflux, the normal stratified squamous is getting converted to intestinal type. Next point, significance. Why are we studying this? Barrett's is pre-malignant lesion, that is, it can progress to cancer. Pre-malignant for adenocarcinoma esophagus. It is pre-malignant for adenocarcinoma esophagus. Next point, grossly, it shows the presence of velvety red mucosa. Grossly, it shows velvety red mucosa with interspersed glistening white areas. Which part is Barrett's? Velvety red or glistening white? Velvety red. Velvety red is Barrett's esophagus. Velvety red is Barrett's esophagus versus glistening white, which is the normal stratified squamous epithelium, versus glistening white, which is the normal stratified squamous epithelium. This is Barrett's esophagus. Next, so before we go further, let us have a look at this. Starting with this image, what we see here is the presence of velvety red mucosa. All this is velvety red. With interspersed, you are able to see the spots I am putting with blue, with interspersed glistening white areas. This velvety red is Barrett's, glistening white is stratified squamous. Blue arrow is glistening white epithelium, glistening white, that is normal stratified squamous. Next, have a look at the microscopy now. What you see here is the normal stratified squamous epithelium, which is getting converted to the columnar type, with presence of numerous goblet cells with inflammation below this. This is Barrett's esophagus. Now, some students can get confused that why is this not adenocarcinoma? Because we are seeing glands here, why is it not adenocarcinoma? Nahi bache, look at the nuclei of the glands. Nuclear polarity is maintained. All the nuclei, they are present on one side of the cell. This is called as nuclear polarity. Nuclear polarity is maintained. That is, they are the benign glands. Hence, this is a case of Barrett's esophagus. This is Barrett's esophagus. Next point. This gets us to our next question, that is question number 15. Cytogenetics of chromophilic renal cell carcinoma. Chromophilic type, it is associated with trisomy 717. By chromophilic we mean the papillary RCC. Question 15, the answer is C. Question number 15, the answer is C, that is trisomy 717. So before we start with our master table of gene mutations, the cancers with the gene mutations, let us start with RCC. Renal cell carcinoma, starting with RCC, that is renal cell carcinoma. First point, if nothing is written, we mean the clear cell. If nothing is written, we mean the clear cell or the conventional RCC associated with VHL mutations. VHL is von Hippel-Lindau. Von Hippel-Lindau mutations present on chromosome. How many alphabets are there in VHL? 3. Present on chromosome 3. Next is papillary. Papillary or chromophilic RCC. Papillary or chromophilic RCC associated with chromosome 7. Associated with chromosome 7. 17. Associated with chromosome 7, 17 and CMET mutations. 7, 17 and CMET mutations. And the last is chromophobe RCC. The name tells you it is phobic of all the chromosomes, so it is associated with deletions or hypodiploidy. It is associated with deletions or hypodiploidy. Next point, continuing with our list of cancers with the gene mutations associated. Next, starting with GIT, FAP, familial adenomatous polyposis, FAP, familial adenomatous polyposis associated with APC gene mutation, present on chromosome 5 versus HNPCC, hereditary non-polyposis colon cancer, HNPCC, associated with DNA mismatch repair, associated with DNA mismatch repair mutations, or the mutations in MSI pathway, that is microsatellite instability pathway, DNA mismatch repair or mutations in MSI, microsatellite instability pathway mutations associated with the genes. The genes involved in MSI start with M, MUTYH, MSH2, MSH6, MLH1. Only exception is PMS1 and 2. PMS1 and 2. This is GIT HNPCC. Next, the next gene mutation is Men's syndromes. Men's syndromes. Men's syndromes. Multiple endocrine neoplasia. Men's syndrome. Men is of three types: Men 1, Men 2A, 2B, Men 1 and Men 2. I am not interested in subdividing it into 2A, 2B. It is the same gene mutation. I am not even concerned with the organs involved here, just the gene mutation. Men 1 is associated with mutation in tumor suppressor gene menin, present on chromosome 11, versus Men 2, which is RET proto-oncogene mutation. RET proto-oncogene mutation present on chromosome 10. Present on chromosome 10. Next, last is BRCA1, BRCA1 and BRCA2. BRCA1 is associated with triple negative breast cancer. BRCA1, triple negative breast cancer. Triple negative is ER, estrogen receptor, progesterone receptor, HER2 receptor. Triple negative, all three are negative. Versus BRCA2, which is ER positive, estrogen receptor positive, Herceptin negative, HER2 negative, luminal B breast cancer. Luminal B breast cancer. Next point, BRCA1 is present on chromosome 17 versus BRCA2, which is present on chromosome 13. Versus BRCA2, which is present on chromosome 13. These are the extremely main, repeatedly asked. This is not a complete list. These are must know tumors with the gene mutations. Next, this gets us to our next question, that is question 16. Pediatrician discovers a large mass in abdomen. Ultrasound is it rises from the right kidney. Most likely tumor. Answer is nephroblastoma or Wilms tumor. C. Nothing else is fitting into this. Malignancy of the childhood arising from the kidney. Wilms tumor. Question 16. The answer is C. Question 16. The answer is C. That is nephroblastoma. Nephroblastoma, also called as Wilms tumor. Nephroblastoma or Wilms tumor. Let us have a look at this in more detail. First point, starting with Wilms tumor. You very well know that it is a childhood malignancy of the kidney. Age group, children is okay, less than 6 years or 1 to 6 years. Age group, 1 to 6 years. It is not a tumor of infancy, 1 to 6 years. Next point, microscopically, it has three components, which are epithelial, stromal, and the blastemal component. It shows three components: epithelial, stromal, blastemal. Which is the most immature component? Blastemal. Most immature, blastemal. The name tells you that. Blastemal. This is the most immature component. Which is the most proliferative one? The one which is the most immature will be most proliferative. So most proliferative is again the blastemal component. So maximum response to chemotherapy. The blastemal has the maximum response to chemotherapy. Maximum response to chemotherapy. Next point. The Wilms tumor. Good prognosis, poor prognosis. It is seen in children. Let's have a soft heart for kids. It has a good prognosis. Good prognosis. So this gets us to the poor prognostic markers in Wilms tumor. This gets us to the poor prognostic markers. Poor prognostic markers in Wilms tumor. Poor prognostic markers in Wilms tumor. Starting with age of the patient. Age more than 2 years is poor prognosis. That is Wilms tumor, which is detected in children more than 2 years, poor prognosis. Next point, microscopically, please put a double star on this. Presence of nuclear anaplasia. Microscopically, the only poor prognostic marker is nuclear anaplasia. Nuclear anaplasia. And the last is presence of nephrogenic res. Nephrogenic res. Nephrogenic res, when we were neonates, they were present in all of us. They normally disappear by the age of 1 year. In a child of Wilms tumor, if nephrogenic res are present, it increases the risk of bilateral Wilms tumor. It increases the risk of bilateral Wilms tumor. So poor prognostic factors, there are 3. Age, nuclear anaplasia, nephrogenic res. Next point, the gene mutation. Gene mutation associated with Wilms tumor is the WT1 gene mutation present on chromosome 11. I'm not interested in the syndromes associated. VAGR, Wilms tumor, aniridia, genital abnormalities, mental retardation. VAGR syndrome, syndromes associated. Wilms tumor, aniridia, genital abnormalities, mental retardation. VAGR syndrome. Others are Beckwith-Wiedemann and Denny-Drash syndrome. Others are Beckwith-Wiedemann and Denny-Drash syndrome. This is Wilms tumor. Next point. So before we go further, let us have a look at these 2 slides. Starting with the first one. What we see here, now I am telling you that this is from a kidney and these 2 slides are given together. What we see is both the slides are from the same patient, a tumor with very varied morphology. This is the epithelial component. All the gland formation that you are seeing is epithelial component. All this is epithelial component with the interspersed everything is the stromal component. Epithelial with stromal component, which are seen in this slide, versus the presence of small round cells. All these are the small round cells, that is blastemal component. So what we are seeing in this slide is a tumor with very varied morphology, epithelial, stromal and blastemal component. So diagnosis, Wilms tumor. Next point. This gets us to our next question, that is question 17. Question 17. Silver stain is performed on the renal biopsy, which shows this. Now, what you see in this slide is the presence of thickened capillary lumens. They are even marked with the arrow. What you are able to see is thickened capillary lumens, making the diagnosis as MGN, membranous glomerulonephritis. Question 17. The answer is B, that is MGN, membranous glomerulonephritis. First point. So before we start with MGN, Let us have a look at the primary nephrotic syndromes. Let us go sequentially. We'll understand the microscopy is better that way. First point, there are 4 primary nephrotic syndromes. The primary nephrotic syndromes, which are MCD, minimal change disease, MGN, membranous glomerulonephritis, MPGN, membranoproliferative glomerulonephritis, FSGS, focal segmental glomerulosclerosis. Next point, MCD. Light microscopy is normal or unremarkable. That means there is no change. Light microscopy is normal or unremarkable. Diagnostic hallmark is electron microscopy. Diagnostic hallmark is electron microscopy, which shows diffuse effacement of foot processes of podocytes, which shows diffuse effacement of the foot processes of podocytes, electron microscopy. Next point, I am not interested in that MGN is the most common nephrotic syndrome in children, good prognosis, dramatic response to steroids, not interested. Next point, MGN, membranous glomerulonephritis. MGN. First point, is it proliferative or non-proliferative in nature? It is a non-proliferative glomerulonephritis. MGN, it is a non-proliferative glomerulonephritis. See, MPGN, membranoproliferative glomerulonephritis, is obviously proliferative. Nobody will ask you that. What is asked is MGN is non-proliferative, showing diffuse thickening of capillary walls. This was what we were seeing in the image. Diffuse thickening of capillary walls. And on the site of deposit in MGN is subendothelial, giving it the specific spike and dome appearance. This is MGN, membranous glomerulonephritis, MGN. Next is MPGN. Membranoproliferative glomerulonephritis, MPGN. The name tells you everything. Everything is proliferating in nature. So if this is the glomerulus, everything is proliferating in nature. That is first point. It is associated with accentuation. Accentuation means increase. Accentuation of lobular architecture. That is, the lobules, the capillaries, they are aggregated together to form lobules. Accentuation of lobular architecture with diagnostic hallmark. Diagnostic hallmark is double contour or the tram track appearance. Tram track is the railway track. Double contour or the tram track appearance arising because of splitting of basement membrane. Please note, splitting of lamina densa, Alport syndrome. Splitting of basement membrane, MPGN. Next, so we have already discussed this, the stain of choice. As a result, the stain of choice in MPGN, the stain used is the silver methenamine stain, because stain specific for basement membrane is silver methenamine. Next point, when everything is proliferating, mesangial cells also proliferate. That is, it is associated with mesangial hypertrophy and proliferation. Mesangial hypertrophy and proliferation. And lastly, neutrophilic infiltration is also seen. Lastly, neutrophilic infiltration is also seen. This is MPGN. whereas FSGS, focal segmental glomerulosclerosis, FSGS shows sclerosis. So before we go further, let us have a look at what it looks like microscopically. Just a sec, just a sec. Let us have a look at the image here only. This is showing you diffuse thickening of capillary lumen, diffuse thickening of the capillary lumen. Diagnosis, MGN, membranous glomerulonephritis. It is not MPG, and I'll show you what it looks like. Next, question number 18. Liver biopsy in chronic right-sided heart failure shows the answer is D. Question 18. Right-sided heart failure, it shows congestion. Liver biopsy shows congestion, giving it grossly which appearance? Grossly called as nutmeg liver. Grossly called as nutmeg liver. What is nutmeg liver? See, have a look at this. What this is showing you is the presence of liver, which looks like a nutmeg. So there are two areas in this. The congested dark brown. There are two areas. The congested dark brown, which are intervening with normal tan brown areas. Congested dark brown intervening with normal tan brown. You're able to see this. Now what is dark brown? Periportal or perivenular? Right-sided heart failure, so venous congestion will be around the central vein. So congested dark brown is perivenular. Congested dark brown is around the central vein. These are the abnormal congested areas versus normal tan brown, which is periportal areas, which is the periportal area. This is the classical nutmeg liver seen in CVC, chronic venous congestion of the liver, seen in chronic venous congestion of the liver associated with right-sided heart failure. Next, this gets us to our next question, that is question 19. Which is characteristic of irreversible injury on electron microscopy? And the answer is B, that is amorphous densities in mitochondria. So question 19, irreversible injury, the answer is amorphous densities in mitochondria. So before we go further, let us have a look at reversible and irreversible cell injury. Starting with reversible cell injury. First point, the earliest change is cellular swelling. Earliest change in reversible cell injury is cellular swelling, which is associated with blibbing, blunting, and loss of microvilli. See, this is sort of obvious. This is the cell with microvilli on top. Now, if cellular swelling is occurring, it leads to cytoplasmic bleb formation, blunting, and loss of microvilli. Next, reversible cell injury. It is also associated with swelling of endoplasmic reticulum, and detachment of polysomes. And lastly, accumulation of small amorphous densities. In mitochondria. accumulation of small amorphous densities in mitochondria. This is reversible. Now please note, small amorphous density is reversible, large amorphous density is irreversible. So if only amorphous density in mitochondria is written, reversible या irreversible? Irreversible, because that amorphous density can be large also, irreversible. Next, so this is reversible cell injury. Next point, this gets us to irreversible cell injury. This gets us to irreversible cell injury. Irreversible cell injury, first point, the first organelle to be affected. Irreversible cell injury, the first organelle to be affected. First organelle to be affected, mitochondria. Mitochondria, where it is associated with accumulation of, where it is associated with accumulation of large amorphous densities, where it is associated with accumulation of large amorphous densities. Next point, the second change in irreversible cell injury are the nuclear changes. Nuclear changes. Nuclei, it shows three things, that is pycnosis, nuclei, pycnosis, karyorrhexis, pycnosis, karyorrhexis and karyolysis. Pycnosis, karyorrhexis and karyolysis. Pycnosis is chromatin condensation. Pycnosis is chromatin or nuclear condensation. Nuclear condensation. Karyorrhexis is fragmentation of the nucleus. Fragmentation of the nucleus. Whereas karyolysis is dissolution of the nucleus. Karyolysis is dissolution of the nucleus. Nuclear changes. And the last point in irreversible cell injury is with necrosis, eosinophilia increases. Eosinophilia increases, basophilia reduces. See, nucleus is blue in a cell. If nucleus is undergoing pycnosis, karyorrhexis, karyolysis, basophilia reduces, eosinophilia increases. This is irreversible cell injury. So the answer to this question is amorphous densities in mitochondria, because amorphous densities can be large also, which is a feature of irreversible cell injury. Next, this gets us to a next question, that is question 20. Caspases are associated with. Caspases are the proteins involved in apoptosis. Apoptosis is associated with embryogenesis. So caspases, question 20, they are associated with embryogenesis. Question 20, caspases, they are associated with embryogenesis. They are associated with embryogenesis. Now before we go further, let us have a look at caspases in more detail. Caspases, these are proteins. These are the proteins which normally are present in inactive form. Proteins which normally are present in inactive form, but they are activated during apoptosis. They are activated during apoptosis. I need not even tell you this, that apoptosis is programmed caspase dependent cell death. So I can divide apoptosis pathways into two major types. Pathways of apoptosis, the intrinsic or the mitochondrial pathway. Intrinsic or the mitochondrial pathway, and the next is extrinsic or Fas ligand pathway. Extrinsic or Fas ligand pathway. First point, which is the major pathway of apoptosis? the intrinsic pathway. Major pathway of apoptosis, the mitochondrial pathway, associated with leakage of cytochrome C from mitochondria. Associated with leakage of cytochrome C from the mitochondria. So I can safely say mitochondrial cytochrome C is involved in electron transport chain. Please put a star on this. It is involved in electron transport chain. Remember biochemistry, ATP formation, mitochondrial cytochrome C, electron transport chain versus cytoplasmic cytochrome C which is involved in apoptosis. So have a good look at the question whether the examiner is asking you about mitochondrial or the cytoplasmic cytochrome C. Have a good look. Next point. This gets us to the other side. Apoptosis had two main pathways, the intrinsic or the mitochondrial and the extrinsic pathway. Extrinsic pathway is mediated by CD95. Next point. Let us make a table of, I need not tell you that during embryogenesis, what is undergoing apoptosis? Notochord and the thyroglossal duct. These are the main structures. Lot of structures are getting remodeled. So caspases are involved in embryogenesis. Let us have a look at more important questions. Apoptosis, there were two pathways, the intrinsic or the mitochondrial pathway, and extrinsic or Fas ligand pathway. Fas ligand pathway. These are the two pathways of apoptosis. Let us make a table of initiator caspases. Initiator caspases and executioner caspases. The initiator caspase for intrinsic pathway is caspase 9 versus extrinsic is caspase 8 and 10. Easy to remember. Suppose we are having a party at home. We are alone, two friends come from outside. It is a party at our home, so we will sit in the middle, 8 and 10 sit on the side. Executioner caspases for both are caspase 3 and 6. Which is the main initiator caspase for extrinsic pathway? 8 or 10? Caspase 8. Which is the main executioner caspase? Caspase 3. Main executioner caspase? Caspase 3. Next point. This gets us to the master table of anti-apoptotic versus pro-apoptotic, pro-apoptotic proteins and the sensors. Anti-apoptotic proteins, pro-apoptotic proteins and the sensors. This table again is asked. First point, easy to remember, anything with an L in it is anti-apoptotic. So BCL2, BCLXL, MCL1 flip anti-apoptotic versus BAX, BAC and SMAC Diablo. I know it's a very sexy name for a pro-apoptotic protein, SMAC Diablo. These are pro-apoptotic. And the sensors are BAD, BIM, Noxa, Puma. Sensors are BAD, BIM, Noxa, Puma. These are the sensors. You do not have to apply on mind what we mean by sensors and stuff. Another important point to be noted here is both anti-apoptotic and pro-apoptotic have BH1 to BH4 proteins. Both have BH1 to BH4 proteins versus sensors which are BH3 only proteins versus sensors which are BH3 only proteins. Has to be remembered, do not overthink this. This is the master table. Done.